We do have kind of a small group that signed up for today. We had about 10, and I know of those 10, a lot, some of them could not make it, and they're looking forward to the recording. So I am going to jump right in here. And, perimenopause and menopause, if you've gone through it, you know that it is not for the faint of heart, and it is different for every woman. Some women go, it's a rougher time for them than others. And what I'd like to do before I get to questions is I would like to do just a really brief overview of what's happening as we go through perimenopause, and then once we hit menopause, just to have a brief overview. I want you to put your questions in the Q&A. If you can't find that, then just go ahead and put it in your chat and I'll check in. But in the Q&A, and then I will respond to them. Once I go through the overview, I will be answering and putting up some questions that I often get in my clinic and that some people have written in, and they may answer the questions that you have. They may or may not. We do have time to go through anything that you might be wondering about as well. Now, before we dive in, I would like to introduce myself. So I'm Cindy Dupuy. I'm a functional medicine practitioner. I have a degree in dietetics and food administration from a long, long, long time ago. I have taken courses from the Institute of Functional Medicine. I've been in private practice for about 23 years and basically helping men and women move through, getting help that they couldn't get help from Western medicine, basically. So it's kind of like beyond what the doctor has ordered. They've kind of given up and they've come to me. And then I moved into the menopause space about 5 to 7 years ago. And there was a couple of reasons for that. One is some of my clients were beginning to get a little bit older and moving into the perimenopause and menopause space. And even though I knew, how they were eating, their lifestyle, all of that, we were losing some ground. And so I used to just kind of ask some cursory questions like, how are you feeling? What's your libido like? And, if they kind of said, hey, I'm doing okay, I would let it go. But there's often a lot of stuff, and we'll be talking about that, that's starting to go below the surface that affects our overall health. It starts to affect our weight, our labs. I was seeing osteopenia and osteoporosis. And so I said, there is something here that I'm ignoring. And so I better dig in here. The other thing is I've been in menopause for almost 25 years. So I did go into it a little bit early at the age of 43 for a variety of reasons. And so I know the terrain pretty well. And I personally have been on HRT for 17 years. So about 7 or 8 of those years of menopause, I was not on HRT. And this is not necessarily about HRT specifically. It is overall about what to be aware of, what to ask for, and again, to get a lot of your questions asked. I mean, this is a big, big, deep, broad subject that you can go hours and hours on. And this is an overview. And again, trying to answer questions that a lot of people have, a lot of the common questions. The other thing that was the impetus for me was that I was looking at my contemporaries and watching them really start to become, infirmed in a way, in that they had aches and pains. They weren't able to do the things that they wanted to do. They were at the doctors so much of the time. And again, weight, health in general, they started to deteriorate at a much faster level than, let's say, me or some other women that I knew. So these are all the reasons why I started to focus on perimenopause and menopause. And I also felt that they were not getting the help that they needed from mainstream medicine. And that is true, and it still goes on, even though there's so much more information out there in the last 5 years. So there's just a plethora of information. Okay, so again, before I get to your questions and questions in general, I'm going to do the brief overview, perimenopause and menopause. I will be talking about a course that I do offer that I'm offering 4 different times during the year. I'd like to tell you a little bit about that. It's called Grace in Transition. It's a lovely course. And then also other ways that you can work with me in case you would like to do that. So with that, I am going to share my screen. I do have a small slide deck here. So, perimenopause is the precursor to menopause, and it typically happens between the ages of 40 to 50. Some women can feel symptomatic for as long as 12 to 10 to even 15 years. Some women might feel symptomatic for 2 or 3 years. It just depends on what's going on in her life. There's a lot of different factors that can determine that. Her lifestyle, thyroid, all of that. So it's often called the second puberty because when a woman goes into, or a young lady actually, goes into puberty, her hormones are usually all over the place. And then when we start to lose our hormones and we start that whole stop and start and sputter and start that we go through when we move into perimenopause, our cycles go off, our periods can become either lighter or heavier. There's all sorts of things that are going on. Often, what we'll start to see, and it can be a roller coaster for some women, right? And that roller coaster, again, can look very different. So, in the background, I don't know how well you can see this. There's 2 women in the foreground here who are on a roller coaster ride, and one is kind of scared, is actually very scared, like, let me get off this ride. And the other one's just having the time of her life. That's how perimenopause can be for different women. So women can have all of these symptoms here or just 1 or 2 of these symptoms here. All right. So again, we often see cycle changes, irregularities, skip periods, shorter, longer cycles, bleeding. We have vasomotor symptoms, which include hot flashes and night sweats, and these may be intermittent. And the night sweats can keep a woman up. Often we'll see sleep issues, trouble falling asleep or staying asleep. And that's often tied to, again, night sweats. It's often tied as well to the loss of progesterone. Okay, so that's really the first hormone that we lose during a perimenopause. And that progesterone is very calming. It can be a vasodilator. There's so many different things that progesterone does. It's kind of like the unsung hero here. She's the sidekick. I call her a sidekick here, and she's not the main star like estradiol is, but she's pretty big here throughout our entire lives, and especially as we move through perimenopause and even menopause. All right, we can experience mood and cognition symptoms, so we can feel a lot more irritable. Our spouses, our children, our coworkers can really get on our nerves. Our hearing sometimes can get a little bit more attuned or astute, and so things like even just chewing can be very irritating. We can feel more anxious again, more depressed, brain fog, and forgetfulness as well. So hard to retrieve words, hard to remember why you went into a room. And all that is due because of fluctuation in our hormones and the beginning of the hormone loss. We can experience physical changes, so breast tenderness, bloating, weight shifts, hair and skin changes. We can, and I didn't put this up here, but I'm going to talk about it right now. We can start seeing some differences in some of our blood work as well. We can see our A1C starting to go up, our cholesterol going up. We can see blood pressure starting to change as well. That tends to happen when we move closer and closer to menopause and once we hit menopause, but we can see this here as well. And then, we can feel the vaginal dryness, and so the comfort of having intimacy kind of goes out the window. So that, along with a loss of libido because of a loss of our hormones, intimacy can become a real issue. And for many couples, that can be an issue for their relationships and just their satisfaction. We can also have increased UTIs because the tissue starts to change, and also the bacteria that whole urinary tract system is part of. Okay, some other things is we can feel more fatigued, we can have joint pain, headaches, worsening PMS, allergies can increase, and we can have increased facial hair, and even the hair on top of our head can start to diminish. So it kind of switches around. All right. So that's basically what's happening during the perimenopause period. And then all of a sudden we hit menopause. And the definition of hitting menopause is kind of an arbitrary one. I mean, it's solid, it's defined, but the definition is kind of arbitrary in that they say that you've hit menopause once you haven't had a period for a full entire year. Okay. I would say that our hormones are probably pretty significantly dropped, our estradiol, progesterone, and even testosterone a little bit before menopause gets here, but that's kind of the dividing line here. And I just want to say that, if a woman hasn't had a period for, let's say, 7 or 8 months, or even 6 months, and she has a period, and then she doesn't have another one for another, 4 to 5 to 6 months, she's in menopause, all right? And you don't have to start counting from that weird one that maybe you had. So just know that. And one of the ways that you can really um, often define it is looking at your FSH and LH levels, which really raise up, go up high once we've hit menopause, just because it's our body's way of saying, hey, we really want this estrogen to be made. We really want this progesterone to be made. Our bodies still want both of those, and it does whatever it can to make them. It's just not through the all ovulatory cycle that we were used to during our fertile years. So, okay, menopause, we've crossed this line. Now, for many women, what that means is they're feeling frazzled and frumpy and fat, and it doesn't have to be that way, okay? So if you are supported in the right way, you getting the things that you need to be supported, which can look different for every single woman, it does not have to be that way. And that's one of the reasons why I have created my course, Women of Certain Way. I feel very, very strongly about this. So menopause, right? It's 3 to 4 decades of our lives. So it's a long time. And we want to be living these last decades feeling vital, feeling vibrant, being able to move, being able to do the things that we want to do. And so we need to support it. And the other thing is that once we moved into menopause, lots of times all of the ups and downs and a lot of the symptoms that we experienced in perimenopause have calmed down. So many women kind of go, whew, I crossed over this finish line and I'm doing okay here. Well, maybe, but what I have found again and again, like I said in my practice, we might look like we're doing okay, but we have to realize that there's a lot of things that are going on below the surface in our bodies that we aren't detecting for many, many years once we move into menopause. And that's because there's so many protective factors that estrogen and progesterone both give our bodies. The high blood pressure, the high cholesterol, all of those things the hormones do have an effect on. So once you've arrived, what can be happening below the surface that we don't really detect, right? They're kind of silent killers, if you want to call them that, is cardiovascular disease, which goes up. It is higher in postmenopausal women. Death cardiovascular disease is higher in women than it has been in men. So we outstretch them, okay, when we in deaths in cardiovascular disease, heart attacks and strokes, when we become menopausal. So that's an issue, and often we don't know what's going on until there's an event, and that's kind of too late, right? And then osteoporosis as well. So osteoporosis, this is really when we start seeing that happen. And most women, and I would say even doctors don't realize that the biggest amount of bone loss that a woman experiences usually is during the first 10 years after menopause. So that's her biggest time of bone loss when the estrogen has really dropped, and then it kind of levels out after that. So, unfortunately, DEXA scans, okay, which is maybe not a perfect way of measuring bone density, but it is the way that we use. It's kind of the gold standard of what we use. There's other things too that can be helpful, but that's not what we're going to get into here today. But often it's not done until a woman is around 65. I get women all the time coming in and they haven't had a DEXA scan. And I ask them to ask their doctors to order it for them. And if it was me, I would say every woman needs to have a DEXA scan just to kind of have a baseline of where she's at the age of probably late 40s, mid to late 40s to get that baseline, and then definitely have it done again a couple of years into menopause. And then, depending on what's happening every 2 to 3 years, depending on what's happening and depending on genetics too. So there's a lot we can do with lifestyle when it comes to osteoporosis, well, anything here. But genetics do play a role whether or not a woman is going to be more susceptible to it. There are other many risk factors. By the way, I do have a YouTube channel and I do talk about osteoporosis on that. I do go into all the risk factors and the lifestyle things that women can do and recommendations and supplementation and all that good stuff. So osteoporosis is a big one here. Diabetes, so the propensity for diabetes goes up once a woman goes into her menopausal years for a lot of different reasons. But one is estrogen. Menopause is going to hit every single organ and tissue in your body. Okay, that's just what's going to happen. And again, everyone's going to be different on which organ or body system it's going to hit. And for some women, the drop in the estrogen is going to make them less insulin sensitive. And so they're going to have more propensity to go into storing fat and becoming diabetic. So that's something that we often see. And by the way, that little fatty belly, that menopause belly, is what I call it, that a lot of menopause women will grow, is due to a couple different reasons. One is bodies do still want to make, and I mentioned this before, estrogen and progesterone and testosterone. And cholesterol is the backbone of that, right? The menobelly is that we make an enzyme through the visceral fat, okay? It's not necessarily a healthy fat, through the visceral fat. And that is the fat that makes enzyme that will turn testosterone into estrogen or estrone, which is not our most favorable type of estrogen, but it gives our body some type of estrogen. So that's one of the reasons why our body does it. Another reason why our body does it is because our inflammation goes up when we lose our hormones. And so in a response to the inflammation, again, that visceral fat can develop. So a lot of different things going on. And again, it's hard for me not to say it all here, but I can't. And then the propensity for Alzheimer's and dementia also starts to go up here. And again, it can be the sensitivity of glucose, which affects the brain. It's inflammation as well that's affecting the brain. So it's a lot of different things that are contributing to Alzheimer's and dementia. And again, we really don't see it happening until it's here. So these are all the things that are going on below the surface. And how do you avoid that, right? I always teach my clients the tests that they need, the lab work that they need to ask for and to learn how to advocate for themselves. And sometimes we have to maybe tell a little bit of a story in order to get it done. And I'm all for that, okay? To get done what you need to have done. And by the way, on my website, and I'll talk about it a little bit later, I do have a lab checklist for perimenopause and menopausal women. Okay, what they need to have done and why they need to have it done. So close monitoring of our lab work is super important during this period of time. Really important, probably more important than any other period in our lives. Okay, so I'm going to go to the questions of what comes into my clinic and what I see, and a couple of these also were written in. So one of the biggest things is, why can't I lose weight? I'm working out like a fiend and I'm not eating much, but I can't lose any weight. Well, often what I'll see, and this starts to happen usually in perimenopause, right, is we need, again, to look at lab work. We need to really see what's going on with the thyroid. And it's not just TSH, it's not just free T4, which is what doctors usually stop at. We need to look at thyroid antibodies. We need to look at free T3 and reverse T3. So again, and we also need to look at your insulin levels. If your insulin levels are high, it's going to be really hard. You're going to have more inflammation, number one. Number two, insulin's a fat-storing hormone. It's going to be really hard to lose weight if your insulin's up. So again, lab work is really important to start peeling away the orange, right? To see, or the onion, I don't know why I said orange, the onion to see exactly what's going on. So, and often, my women are trying to lose weight and they're not eating enough protein, they're not eating enough vegetables, they're not getting the nutrients that they need. And sometimes they're even over exercising and under eating. And the body goes into this fight or flight position here, and this, like, oh my gosh, we have to conserve energy. So just the whole metabolism gets thrown off. So we actually have to be nicer to ourselves, and we have to trust the person that's leading us, because sometimes it's like, oh, if I eat this, I'm going to gain weight. No, you're not. But we have to support your body in the right way as we start making the changes. Okay. All right. Why has my cholesterol gone up? I've already kind of talked about that. Number one, our bodies want to make hormones still, and cholesterol is a backbone of hormones. And then also inflammation will often go up, and LDL, the bad cholesterol, is produced in response to increased inflammation in the body. Now, it is interesting, and I've seen it time and time again. It's not really interesting, it just makes total sense. And that when one of my clients goes on HRT, and it's an adequate amount, it's not just you'll be a little bit tiny, it's adequate amount, the cholesterol will go down, boom, just like that. Okay, so it just supports what I just said here. Why do I have so many aches and pains? I already mentioned that when we lose our hormones, estrogen and progesterone play a huge role in inflammation. Estrogen plays a huge role in being able to make collagen and keeping our ligaments and our joints happy. And we just have more inflammation. And I don't know how many of you have heard of frozen shoulder, but it's where a woman can't even lift her arm up. And you put some estrogen in her, and that will usually be repaired. So again, we can see so much polypharmacy as a result of what's happening when we're moving into perimenopause and menopause. And it doesn't have to be that way. And you do have to weigh the risks and the benefits, right, of the pharmaceuticals and then the HRT. And it's different for every single one. I love this next one. My doctor told me I can't take hormones because there's cancer in my family. You don't have active cancer right now, okay? Just because there is cancer in your family does not mean that you are going to get cancer. Just because you have the BRCA gene does not mean you are going to get cancer. And just because you don't have the BRCA gene does not mean that you're not going to get cancer. Do our hormones, estrogen and progesterone, that we lived with for, I don't know, 40, 45 years, or no, not that long, maybe 30 years of our lives. Did that cause any cancer? No, it did not. Our bodies did very well with it. So HRT does not cause cancer. And in fact, because it does reduce the inflammation, it does keep our numbers better, okay, overall, our bodies are often in a better position to handle any type of cancer that may come on board. Now, if you have active cancer and it is hormone driven, that wouldn't be a time to take, hormones. But to be told no, it just tells me, and it should tell you, that your doctor is not up to date with the literature that is out there, which would not be surprising because most doctors have not been trained in perimenopause and menopause. It just wasn't part of the curriculum and has not been for 3 decades. Hormone replacement therapy also hasn't been part of the curriculum. Not just perimenopause and menopause, but hormone replacement therapy. Again, this is a WH study that was about 3 decades ago. So they're not up to date. They're very, very busy. It's hard for them to stay up to date, and they really have to have an impetus and a reason to do so. So here we are, okay? All right, I'm worried about osteoporosis. What's the best way to prevent it? So it's interesting how, you know, estrogen replacement was approved by the FDA in 1985 to prevent osteoporosis. Now, I say it's interesting because there is not one client that's ever come into my office who's been diagnosed with osteoporosis that was ever suggested going on HRT in order to help or prevent osteoporosis or to reduce and reversing the osteoporosis. Okay, not one, although it was proved very effective in 1985. It basically being prescribed right after the Women's Health Initiative. Again, that was, back in 2002. And interestingly enough, is the biphosphonates really came to market in 2003, a year after the Women's Health Initiative results came out. And the spokesperson for Boniva, which is a bisphosphonate, was Sally Fields of the Flying Nun. So yes, I'm aging myself. So some of you who are younger have no idea what I'm talking about. But anyway, that's when it came out. So let's say you're not comfortable taking HRT. All right, fine. So you really do need to look at your diet. You do need to look at the amount of protein that you're getting and get adequate amounts. You do need to be moving your body. You do need to put a load on your bones. And it depends. The load depends on, how much bone loss you have had. You need to be careful. You have a lot of loss in the spine. So activity, making sure that you keep your fragility score down. And what I mean by that is we can have maybe dense bones. They may not be strong, but they can be dense. And again, that's a whole nother thing to talk about. But if we don't have balance, if we don't have agility, okay, we become more fragile. So we have to keep that up. We have to work on our balance. We have to work on our flexibility just as much as our strength. And all of that puts a torque on our bones, which strengthens them. So whenever we put a load or we put a stressor on our bones, it strengthens them. They have to move and they have to strengthen in order to that load. Make sure that you're keeping up to date with your DEXA scans, and there's also some blood work that you can do, which can be helpful too, in addition to. All right, my doctor is worried about giving me estrogen because of a risk of stroke in the family. Oh, yeah. She wants to put me on testosterone instead, and what are my thoughts? So this particular client, I remember her very well. And actually, I need to follow up with her because I wonder how she's doing with the testosterone only. Her doctor was very caring. She'd been with her doctor for a long time. She trusted her very much. And so she was going to do the protocol that her doctor laid out for her, even though I had recommended that she go on estrogen. And the thing is that we can make estrogen from testosterone, okay? We do make some. And it's done through that aromatase enzyme. We have an enzyme in our body that will convert it. It doesn't convert it to the point where it's nearly as beneficial as taking estrogen replacement. Okay. You don't get the same benefits. Am I happy that she was willing to give her something? Yes, I am. Do I think testosterone can help? Yes, it can. It can help, um, again, maybe lower a little bit of inflammation and maybe make muscle building a little bit easier for her and maybe make metabolic health a little bit better. It can also help with our bones because estrogen prevents the breakdown of our bones, but testosterone is an anabolic hormone and it actually can help build that. So there's probably some benefits here, but it's not the same as what you would receive if you were taking estrogen in addition to maybe the testosterone. And do we need to worry about stroke? Not necessarily. And I'm going to talk about that in the next question. Okay. So this client, and I get a lot of older clients coming to me because they're not adequately being helped by their doctors. And she's 73, and her doctor told her that she's too old to go on hormones. And is that true? No, it is not true. But it's really, really hard to get doctors to start a woman on hormones. They might be willing to do vaginal, okay? I hope so. But systemic, no, they are not going to be willing to do that. And that again comes from the WHI. And actually, the WHI was started initially to see if it helped to reduce cardiovascular disease, interestingly enough. And the deal is, and I think meta-analysis and interpretations of different studies is one of the reasons why we have this idea in our heads, doctors do across the board, that it can cause a stroke if we start it too late. That's the biggest problem that doctors have. They're worried about that. The deal is that starting hormone replacement therapy within the first 10 years of going into menopause can be very beneficial as far as reducing cardiovascular disease. Okay. It's very beneficial. Now, after that 10-year window, okay, that benefit greatly reduces. And if you were to start a woman 10 to 15 or more after she goes into menopause, you're not going to be able to reverse damage that could have been done, right? During those years where she wasn't on any HRT. So it's not going to reverse and reduce the amount of plaque that's already laid down there. It's not going to perhaps reduce or reverse any damage that's happened to her heart. Okay. So it's not going to do that, but what it will do is it will reduce inflammation and it will increase her ability to have that metabolic flexibility, so handling glucose and insulin. Also, very important, the type of hormones that they used during the WHI study was oral. The estrogen was oral and it wasn't bioidentical. The progesterone was a progestin and also not bioidentical. Both of those have their own problems. And the other thing is if you take estrogen orally, it has to go through the pass in the liver. There is a little bit more propensity for inflammation to happen. So I would never do an oral type of estrogen. There's no reason to, okay, in women. There's so many other different ways of administering HRT, and I definitely wouldn't do it in a woman who's older, okay? So those two reasons. So the studies, the way they've been interpreted, and then the type of hormone that they used during the WHI both contributed to this mindset that you can have an increase of cardiovascular disease if you put a woman who is older on HRT. Now, having said that, you would want to start a woman very slowly. You would want to keep an eye on her inflammatory markers. So doing really good lab work and keeping an eye, talking to her, blood pressure, all of these things you're going to want to do. You don't want to start an older woman on a high amount of HRT because her receptor sites have been pretty dormant. and she can not feel good. Okay. So you want to start her on the lowest dose and just go slowly and see how she responds. Okay. When is a good time to start HRT? It can be during the perimenopausal years. All right. Again, it depends on the woman, depends on her symptoms. I would say most women probably need to start on progesterone during their perimenopausal years for sleep, for calming things down, to support the thyroid. Progesterone is very important with that. Um, and then some women also need to have estrogen, especially if it's kind of all over the place. Some women do, some women don't. All right. If you're having heavy periods, we probably want to start with that progesterone, get that up to oppose the estrogen. But some women, if they feel that depression or that anxiety, she might need just a little top off here. And there are some good creams that you can get where you don't have to have a prescription. I have two brands that I do like to use that I feel very comfortable with. And one is with Karen Martell, and the other one is Annika Becca's creams as well. And you can just kind of top them off yourself. You can play with it. So many people are afraid to really play with their hormones. And I get it. And I think there should be some caution. But when you kind of get used to things, it doesn't have to be an all or nothing. There is some flexibility. Okay. All right. So during perimenopause, I think you can start it. The other thing I do want to caution, though, before I move on to the next question, is that I'm glad there are some doctors who are willing to start their patients on HRT in perimenopause, but again, it's super, super important to make sure you have a full workup on all of your inflammatory markers and especially your thyroid panel, because low thyroid can mimic so many signs of, low hormones when it's not actually going on. So it's really important to have good lab work so you know exactly what's going on and you're not covering up one for the other. Uh, experiencing. There's a typo. Sorry about that, guys. Okay, if I'm not experiencing any symptoms of menopause, should I still take HRT? That's up to you, right? But I do want to bring you back to the slide where I showed things that are happening below the surface, possibly. And I would say my experience has been that one of those things that I listed there is often happening. Okay, maybe at a very slow rate. If a woman really takes care of herself, and there are some women out there who take excellent care of themselves, they know what they're doing. Okay, they can go along for a long time. That's fine. I just want to make sure that your labs, your bones, all of that are being monitored so you know what's happening below that surface. Okay. All right. Is it safe to take vaginal estrogen after cancer? Yes, it is. And I think more and more oncologists and more OBGYNs and more gynecologists as well are recognizing that fact. Vaginal estrogen is usually estriol. Sometimes it's estradiol, but estriol is the weakest form and it is not systemic. So it stays in that area. And there's so many benefits with supporting the urogenital tract. Very, very important. Okay. I've talked a lot about HRT, right? I mentioned it a lot here because I think a lot of people are curious about it, but it's just the icing on the cake. And I really want to stress that. It's just like you can't out supplement bad lifestyle and diet. You can't out prescription a bad lifestyle and diet. You can't out hormone a bad lifestyle and diet. Okay. You need to be doing all of these things. Now I like to see the lifestyle part put in first before the HRT, but sometimes it doesn't happen that way. Sometimes a woman's feeling so horrible that she needs a little bit of a lift, and I'm perfectly fine with that. Okay. So again, HRT is not the end all be all. We have to have proper nutrition and proper nutrition for that woman. We have to have really good gut health, right? Um, we need to know what our body's doing with our hormones. And I like something called the Dutch test, which is something I'm not going to get into, but it tells us what our body does with the hormones that we have. I think that's important. But gut health is super important as far as inflammation is concerned, as far as the nutrients that we're able to break down and absorb, as far as what we do with our hormones, because our hormones are processed in our liver and then combined with our bile and then taken to our digestive system and then dumped out in our poops. And there's so much that can go on in between all that that can make things go awry. So we have to have a healthy digestive system. And some women are really hit in that area. Lifestyle, which encompasses sleep and body movement and stress reduction and mindset as well. And then our environment plays a huge role. And I'm talking about our exposure to toxins. So in our foods, and there's so many different areas. And that's, I talk about all of these things in the course. And we also have to, again, look at adrenal and thyroid health. Okay. So here we are at Women of a Certain Age. And again, I've mentioned it quite a few times. So that is the name of the course that um, I have. And actually, the next session, which is starting February 2nd, has closed. In other words, it's no longer open for enrollment. So, enrollment, if you're interested in it, it can happen today, but the course is actually not going to start until April 6th. Okay. But I do want to tell you about it, okay, in case you're interested, and also to let you know if you do enroll for the course now, you don't get me now, but you do get the first 3 modules and you get all of the course handbook, notebook, and so there's 3 different, actually, there's a lot of information you get once you enroll. So you can get started on it if you want. You get a head start here. But what it includes, it's an 8-week course. We have Zoom meetings every week. So you get me, you get a community of women. The last time that we did it, it was just an awesome, awesome community. So you get a community of women that share, that support each other, that are walking this journey together, which I think we do so much better in than by ourselves, which is why I think 8 weeks can be kind of a long time, but it's also a really nice length of time to get to know each other, to get to really instill different types of way of eating and moving. We do have a daily moving accountability group. It's part of the whole thing. So we check in daily with movement. It's not a competition. It's just holding each other and supporting each other to implement, new ways of moving, maybe upping things a little bit, or if we already have that part dialed in, we can be there to support others. You get a guide to essential lab work. Again, I talked about the Zoom meetings. You get menus and recipes. You get a 20% discount on any supplements from my online dispensary, and then an opportunity to work with me one-on-one at 30% off. And all of this is for $247. So it's really an inexpensive way to get a ton of information and to get a ton of support so that you can live your life the way that you want to live it. So that is the whole point, because getting support in this arena can be expensive. If anyone's been looking out there, you know it's expensive. You know that you can't get that from our mainstream medicines, or if you do, they're concierge on top of it. So you're paying a monthly fee or yearly fee on top of it. So this is a way, at least you know what to ask for and how to be advocates for yourselves. So when I send a follow-up email, which will have a recording of this webinar, there'll be some links to the course page so you can find out more about it and to enroll from there if you want. My website is alivingbalance.net. And to get to the course, either you look for menopause course or you go after net / and then course and you'll get to it. There are other ways to work with me if you'd like. Probably the lowest entry point, doesn't mean it's bad, but it's the lowest cost entry point, would be a lab and supplement review. So I look at current labs that you've had done. I might make suggestions to have more lab work done, and then we meet. And so I look at your labs, I look at what you're eating, I look at your supplements, I look at everything. And then we come up with a protocol of what you need when it comes to, nutrition, lifestyle, supplements, all of that. So that's a one-time deal. Okay. And then I have an ALB package that includes 5 sessions with me. So if someone needs a little bit more support, all of this is on my website. And then I also offer labs. All right. So I can order labs for my clients and they're at cash prices. So they're very, very reasonable. So if you don't want to go to your doctor, you just come to me. All right. And say, I want your perimenopause or menopause, or if you're a male, you can have the male panel too. Get that done. We review it, we go over it. And again, we have that consultation and you have a protocol for yourself. So those are different ways that you can work with me. Okay. My vision, and I think I've already said it, is to help as many women as I can. And I kind of already said that's why I do the course. And so they can, lead amazing lives during the last part of their lifespan and to educate and empower and to help them be advocates. So that is pretty much the end here. If you have any questions or comments, okay. So you can unmute yourselves and I think, or write in the chat. And, any questions that you might have that I did not get to, please let me know or any comments. This is the time. And I'll give you, I know it takes a minute. And again, it can be in the chat area. That's fine. And thank you for coming. Okay. Again, in the follow-up email, which will come either today or tomorrow, you will, you're welcome. You have a link to my website, which will give you more information. And someone just said, thank you in the chat. My pleasure. All right, everybody. Have a wonderful rest of your Saturday. Thank you for being curious and thank you for being here. I appreciate that. Bye-bye.